Assalamu alaikum wa rahmatullah. Today we're going to be talking about Obsessive Compulsive Disorder, OCD, something that affects loads of people. I think the percentage, it says it affects 1.2% of the UK population. That's over 750,000 individuals. It's something which is at least once in their lifetime. Now, this is something which is a big topic, especially in the Muslim community as well. Because we have something called Waswas, right, which is a form of obsessive compulsive disorder. We could say we're going to speak about that. And again, it's myself, Abdulwahid, graduate of Islamic University of Medina, and my co-host Hashil. Assalamu alaikum wa rahmatullah.
Wa alaikum assalam wa barakatuh.
Already been introduced, but introduce yourself again to those that maybe haven't seen the first podcast.
Barakallahu feek, jazakumullah khair, bismillahir rahmanir rahim, alhamdulillahi rabbil alameen, wa sallallahu wa sallam wa baraka ala nabiyyina Muhammad wa ala alihi wa sahbihi sallam ajma'in. Jazakumullah khair for bringing me on again. Barakallahu feek, Sheikh. For those that don't know, my name is Hashil Hatmi, and I'm a psychological wellbeing practitioner. I am a low-intensity CBT therapist and a wellbeing coach. And alhamdulillah, we're here talking about OCD, Obsessive Compulsive Disorder. As you mentioned, it's affecting so many people around the world. Here in the UK alone, it's a very, very challenging condition, and I hope inshallah we can talk more about it. And then integrating, understanding the Islamic side of it as well as the evidence-based part about it as well, inshallah.
Yeah, and I think one of the things, the purposes behind these discussions is looking at Islamic psychology as opposed to just psychology. So looking at how we integrate Islamic principles with the study of mental health and human behavior. Okay, the first thing, let's jump straight into what we're going to speak about, I think is, well, there's a couple of things we're going to speak about.
Sure.
The first thing is, what is OCD, i.e. Obsessive Compulsive Disorder, in terms of, how is it defined basically? What's obsessive, and then what becomes compulsive to make it a disorder?
No. Bismillah. So it's a long-term, potentially very disabling and debilitating condition that involves two things: obsession, or obsessive and intrusive thoughts, and compulsive behaviors. All right, what are they exactly? Obsessions, these are unwanted, intrusive thoughts or urges or even images that cause distress, while compulsions or compulsive behavior, these are repetitive behaviors or rituals, as they call, mental acts that are performed in order to reduce the anxiety caused by the obsession. So the obsessions cause a person to become very anxious, and then in order for them to elevate and relieve themselves from that anxiety, they have to engage in a compulsive behavior.
Yeah, so there's some subtypes which are very common. I mean, some of them the ones that come up in my work is two types that I can speak about, which is the one of the connected to wudu and purification, which is the religious type, obviously, because it's connected specifically to an act of worship in religion, which is they start performing wudu, and then a thought comes up that they haven't washed a previous limb properly. So then the action that comes from that is they go back and wash that limb again. So that's one of them. The other one which comes up is that one where they do an action, they've done an action, completed an action, and like, for example, I'll give you an example of what's happened in the past. Questions I've got. Someone says, okay, look, their mum was there and the pen dropped on the floor. They picked up the pen from the floor, and they felt like did they make ruku' to their mum? So have they committed shirk?
Oh.
And do they have to take the shahada again? Because now and this is the one from obviously the Waswas, isn't it? I think there's a hadith that mentions, shaitan comes to a person, right? The hadith we're going to speak about a bit later, and says who created, who created, until it gets to, and there's a cure for that as well. We're going to speak about that a bit later.
Oh.
So these are two types. These are both pertaining to religion, right? What are the other subtypes that are common in terms of?
One of the most common ones is contamination.
Yeah.
So just the fear of being contaminated. Hence why you find people this sometimes can even be related to the issue of wudu. Maybe it's not about it can get into the wudu area because you feel like your wudu has been invalid and something contaminated it, and so on and so forth, which leads a person to make wudu over 10 times perhaps, or even more than that. You have harm OCD, so there's the fear of you're going to harm someone. Again, religious OCD, what they call scrupulosity. There's the perfectionism OCD. So a person is worried that they're trying to be so perfect, or they feel like they're very immoral in their behavior. There's also pure OCD, or pure O as they call it. This is literally everything to do with thoughts. It's just about mental obsessions, not much of compulsive behavior. That's why they call it pure O, or pure obsession is just obsessions alone. Then there's stuff about existential OCD or identity OCD. So you're questioning yourself, you're questioning your existence, and subhanAllah, this is what's amazing, is that this has been addressed in a number of hadith and a number of books. This has been addressed, such as the hadith we're going to mention later, but you just mentioned recently that shaitan can come to a person and ask, allow you to make a lot of doubts. And now you get a person even asking themselves, for example, in the issue of marriage, some people are asking, like, I saw something and now should I divorce my wife, yes or no? Did I do it correctly? Did I not do it correctly? And as we say in Arabic, rasik khalas fi duwar. You've literally gone into a huge cycle, and you're in this vicious cycle. You don't know what else to do. Allah musta'an.
So just another example that comes up a lot, just to put out the examples, the cases that have come to me, because when you spoke about contamination, fear of germs, the other one is, when a person goes toilet, obviously najasa, and then afterwards they feel like, for example, there's been a drop of urine, for example, this can come out. So then they say, well, they have to go back and, wash and check again, and, is their prayer valid and stuff like that. So it can have an impact on, obviously, a person's worship or their life. So it can become, so I think there's another distinction between the thoughts, right, the thinking something, and then it becoming overpowering, that the scholars call it qahar, isn't it? Where it overpowers a person up until they literally going to be performing wudu and praying, and it's going to take them a whole hour, right, to perform what would take ordinarily 5-10 minutes, right? Because they can't get out of that cycle of redoing wudu and repraying, and redoing wudu and repraying, and redoing wudu and repraying again. So now it's become overpowering, right? So hopefully in today's discussion, we'll look at some hadith and ayat, as well as history of some of the scholars that have spoken about it.
Exactly, yeah.
Maybe do a bit of a comparison between, for example, the remedies that we have in Islamic principles with what you practice in terms of the therapies that are there, and then just take it from there and see how it goes. So let's begin. You mentioned, for example, there's a hadith. You mentioned the hadith, or I started off with a hadith that we're going to speak about now.
Yes.
What's that hadith, and how does it relate to OCD? And also, let's start with that, I guess, that hadith.
The hadith, what it says is, the hadith is mentioned in Bukhari and Muslim, where the Prophet ﷺ, he said, يأتي الشيطان أحدكم فيقول من خلق كذا وكذا حتى يقول له من خلق ربك أو من خلق ربك فإذا بلغ ذلك فليستعذ بالله ولينتهي عفوا, which in English basically translates as that shaitan will come to you and he will say, who created such and such, and it will go on until he says or asks, who created your Lord? When he reaches that point, let him seek refuge in Allah and stop immediately. Just stop. Yantahi, just stop it from there. So closing the doors. Because as you close the door, you're closing the door from what? From continuous spiraling and obsessions, and it will just get worse and worse and worse until basically, based on this hadith, it can lead you to be led astray, or to go divert from Islam. So it can lead you to wallahu billah, perhaps even kufr. And because to believe that something created Allah subhanahu wa ta'ala. So it's teaching us that these things will happen and it will come. Normalizing that shaitan will approach us. A and B is understanding what to do. So he gave us the problem and he gave us the solution.
So this hadith, I guess, it's like it gives you, like you said, two aspects. It gives us this aspect of there's shaitan, he exists, right? So this thought is not always your own. It could be a Waswas from shaitan, right? Shaitan's come to one of you. And I guess another aspect of it is, okay, when that does happen, what should you do, right? So when the situation is there, like let's take that example that I mentioned. Oh, did I make sajda to my mum when they picked up the pen, for example, right? It felt like I was, so that's the thought, isn't it? That's shaitan comes to saying that you've done an act of kufr, potentially, because the hadith ends up as who created Allah, right? So it mentions the dhikr, say, أعوذ بالله من الشيطان الرجيم, right? فليستعذ, so to seek Allah's refuge, right? From shaitan, right? And then the second one is فلينتهي, and then stop. Like get back to the present and stop thinking. So I think, I mean, one of the, and then we're speaking about Waswas, right? And there's the Ma'awwadatan at the end of the Qur'an, the last two surahs, which is protection again from, and from that is the protection from Waswas, isn't it?
Min sharri waswasil khannas.
Min sharri waswasil khannas, exactly. So, you know, and that's the persistent whisperer. So, i.e., the one that's over and over again. So, I think one aspect of it is you have, you know, outside whispers. Also, we were discussing earlier. Maybe it's worth elaborating on a bit. Is that it's not just it's nobody's protected from the whispers of shaitan,
yeah, sure.
Right? So it's not an abnormal. We call it obsessive compulsive disorder, but the thoughts themselves are not necessarily a disorder, isn't it? It's something which I think we mentioned.
We were talking about, like, a person can experience obsessions.
Yeah.
You might have that. Some people have it naturally in their personality, that they have, oh, this person has an OCD sort of personality. Now, bear in mind, there is an actual disorder called obsessive compulsive personality disorder, but what is the difference between normal, abnormal? A disorder is something that's abnormal. Normal is, okay, it comes about, you do get an obsession, but it's not impacting your daily life. It's not impacting your sleep, it's not impacting your appetite, it's not impacting how you go on about your day to day. Whereas a disorder, what is abnormal is when it is having a significant impact on your day-to-day life. That's why when these diagnoses are being given, they have to look at the duration. How long has this been happening? And in this duration, have you noticed that this has been having a significant impact on your day-to-day life, your daily functioning? If the case is yes, then they look into that and it's perhaps considered as a disorder. But if it's not, then it's something that is something that's considered normal. Not to push it aside and say, you know, just get on with your day, but it's about being aware that what is normal, what is not. Because again, no one's exempted from it. Adam alayhi salam, Allah subhanahu wa ta'ala, what he mentioned, that Iblis went to him. In numerous occasions in the Qur'an, he mentions that he went to him. هَلْ أَدُلَّكَ, shall I not tell you, بِشَجَرَةٍ مُلْكٍ, should I not tell you about a tree that's in Jannah? And he told him that you're going to have this tree forever. He's already in Jannah. But if Adam alayhi salam fell into the traps of shaitan, he fell into that waswasa, then who are we? The first of creation, our father, the first of creation, the first of the prophets, the first of creation. If he fell into it, then anyone can fall into it. So no one is exempt. Yeah. And I think I was just telling you earlier that even Imam Ahmed, one of his companions saw him, Ishaq ibn Ibrahim, and he saw that Imam Ahmed was praying, and he did like some indication with his finger during Salah, and he asked him, what were you doing exactly? And Imam Ahmed, he said, I was in the state of tahara, I was in the state of purity. Then shaitan came to me and he said, you are not in the state of purity. So he kept on fighting that obsession. And that is to show you that it doesn't matter how religious you are, how practicing you may be, no one is exempt. He will come to us, but it's about understanding that it's first of all recognizing that it's him, and then finding a way to close the door and not allowing him to go any further on.
And one of the things that I've kind of come across is when we're looking at the ayat that you mentioned, for example, Satan, Waswas ilayhi shaitan, he whispered to him, and then it was, you know, shaitan might come to a person and come to them from an angle of their fears, i.e. their doubts or their anxieties, for example. So OCD is attached to somewhat anxieties, also to doubts, which we spoke about as well. I.e. not praying properly, or for example, not being clean enough, fear of punishment, i.e. you won't be forgiven, you're sinful, there's like, and then it becomes something which they act on, maybe negatively in the wrong way as well sometimes. Sure. There's a hadith and this, I guess, is a way of reassurance for many people that might have OCD or suffer from obsessive compulsive thoughts, obsessive thoughts and compulsive actions, where the Messenger of Allah said, "Inna Allah tajawazat an ummati ma yatahaddath or tatahaddath bi anfusaha ma lam ta'mal bihi." Right. So Allah has overlooked from my ummah their thoughts, i.e. what they think about, or lam tatakallam bihi or ta'mal bihi, both of them.
No.
So long as they don't speak on it or act upon it. So someone might have, for example, these recurring thoughts of, like, they drive down the road and they, for example, have this scenario happening in their head, right, where an accident's happened or where they've crashed and killed somebody, or, do you get what I mean? And if they realise that it's just a thought and they're not taking into account for their thoughts, it's like, do you get what I mean? It's not something which you're blameworthy for because it's a thought, right? Allah doesn't take into account for what goes through your mind in terms of what you're thinking. So long as you don't speak on it, it doesn't translate into an actual action, which is a sin we're talking about here. So we're talking about the realm of, not necessarily, we're talking about the realm of a person's desires having an effect on them as well, where their obsessive compulsive obsessive thoughts leads to actions which are haram sometimes, right? Actually, they actually do something which is impermissible as well. So there's that aspect as well that we're speaking about.
Exactly. SubhanAllah, you're going to be thinking of some people when they're driving, for example, they stay out of a particular lane, whether it's the left or the right or the middle, and there's an obsession around that. There's a fear. There's a fear that if I'm on this lane, I'm safe, but if I'm on the left or the right, for example, I don't know, I might get run over. Let's say on the left, which is usually the fast lane, someone's really going to either take over me. What's going to happen if there's going to be one of the vans or one of the actual trucks and etc. So it boils down to a fear. An escalated fear, and because of that, I have to do something to make me feel relieved, i.e. the compulsion. Exactly.
The action that they do.
And actually,
so I guess in that scenario, for example, them finding a strategy which allows them to mitigate the fear, means like I'll just drive on the slow lane, right? As long as that stops the compulsion or stops the thought, isn't that a good thing? Isn't that a way of dealing with OCD? They've learned to manage it by way of seeing that doing that action, or is that actually, no, that is OCD, that's the manifestation of OCD.
I mean, it depends on if they're doing it too many times. So again, it all goes back to, are they doing it repetitively a lot? Sometimes if it helps, alhamdulillah. If not, then if it becomes a problem when if they continue to repeat those compulsive behaviors.
And you reminded me of something. When I'm driving, you have two types of what's it called? Passengers, right? A passenger who, like, you're too close to the car, you're too close to they're almost envisioning an accident happen.
They're grilling you as you're driving.
They're grilling you as you're driving. And those that just sit down calmly and they're not afraid of the fact that you're close to that car and stuff like that. So like I think a lot of it's a fear, isn't it?
I wanted to just mention that compulsions are of two types: overt and covert. Overt are the sort of they're the ones that are observable. They're the things that we do that people can observe. We can observe and other people can observe the things that we do repeatedly, such as washing hands, making wudu again, double checking things. Covert is the more mental one, which is like counting or repeating certain phrases. So, it's important to understand that they could be behavioral or observable, overt, or covert. They're more mental. Just there's something. There's an obsession, and I just can't. But it's not. Sorry, not the obsession, but the compulsive behavior is done mentally.
It's not done externally.
It's not done externally. It's done internally in our heads. Mentally.
So I think to just summarise, intrusive thoughts are not sins. If a person knows that, it's a way for them to feel a bit more relaxed and less anxious, I'm assuming, right? Once they understand the Hadith says that Allah has pardoned and overlooked and forgiven what we think, right? As long as we don't stop and not speak about it. So an intrusive thought in itself is not a sin. That's important to understand. So if you know that, then you don't have to worry about, this intrusive thought that I have I now, does that necessitate I've done an action which is kufr or ma'asi or disbelief and disobedience, right?
Allah and the Messenger have reassured us on both ends, because what I mean by both ends, this issue, even with mental, like I think I mentioned this to you earlier, that OCD unanimously, this is an ijma', unanimously agreed by all mental health professionals, is one of the toughest, most challenging conditions to deal with. Even the seniors, I've had senior supervisors tell me that this is very challenging. Psychiatrists even struggle. Therapists, counselors, all of them struggle because it's very complex. And not only that, it's important to understand this tends to get mixed up a lot, which is intrusive thoughts and obsessions are not delusions or hallucinations or paranoia. Intrusive thoughts and obsessions are unwanted, but it's under what is neurosis, which is as you have these problems, they're under the frame of sanity. Whereas insanity, psychosis, this is where hallucinations, whether auditory, where you hear them, or visual, you're seeing things or hearing things that are not there. Delusions are what we call false beliefs. So with obsessions and intrusive thoughts, you have these thoughts and obsessions, but they're unwanted. You know they're not true, but you just can't help but to have them. Whereas a delusion is when you actually have a false belief in something, you actually believe this to be true. I'm paranoid because I feel like someone is going to harm me or something is going to happen. And subhanAllah, on this end you have, in terms of like obsessions, intrusive thoughts, as the hadith mentions, tajawuz. Tajawuz even means that Allah is overlooked, pardoned. From the Arabic language, tajawuz even is overlooked. On the side of psychosis, Allah, what does the Prophet ﷺ mentioned? He mentioned that 3 people the pen has been lifted over 3 people, and from them is the one who's insane until their sanity comes back. Yep. So it's to show you the rahmah of Allah subhanahu wa ta'ala on both ends. Yeah. That because we might struggle, we might think, what's my iman, the status of my iman, and it's to reassure us that these things will naturally happen, but Allah subhanahu wa ta'ala has looked over them bi'idhnillahi ta'ala.
Yeah. So a person that has OCD and these thoughts shouldn't feel guilty or shame that, do you know what I mean? My iman is weak because of this and stuff like that. That's not the case.
It's like an affirmation, Shaykh. And many people are looking for affirmations. Yeah. Imagine an affirmation from both the Qur'an and the Sunnah telling us that you're okay, you're not going to be judged for having this. Yeah. Wallahu a'lam.
So, okay, that's we've mentioned the ayah, so we've mentioned the examples from the Qur'an, we've mentioned Hadith of the Messenger of Allah, so like look at the topic of Waswas and look at the topic of thoughts and responses to them, seeking Allah's protection, as well as wayantahi, stop, right? So, and the fact that, don't speak, don't act upon it. There's also, historically, if we look at, for example, and we're going to do a comparison shortly, we look at the scholars of the past, they addressed this issue and they spoke about this issue. They didn't just not talk about it. I think one of the early ones that I've come across in my reading and research is Al-Balakhi, when he speaks about what's, I think, equivalent to or similar to ACT. You can explain that in a minute to the audience, as a therapy, which is basically, he says, look, you're going to get this intrusive thought. I mean, there's different ways of therapy, we'll look at that shortly, but Al-Balakhi, I think what he's known for is the fact that because where humans have existed since Adam alayhi salam, so this has been an issue since that time, right? So you're going to get this thought, okay, acknowledge that, recognize it for what it is. Oh, there you go, there's that intrusive thought again that's come along. Right, and then park it, and then come back to the present. Right, that's basically the summary of what he says, and then continue what you're doing. Like, come back to the present. I'll recognize it for what it is, ignore it, dismiss it, come back to the present. A lot of the advice of the scholars, when you look at them and someone comes to them and says, "I've got Waswas," or they mention the situation, they always say the same thing. Look, just dismiss it. Okay, for a person that's got, qahri, the one which is really like on them properly, overpowering them, let's say overpowering OCD, right? It's not easy to do. That's why you said that it's the most difficult treatment, one of the most challenging, to treat. But generally speaking, if they perhaps had that advice earlier on, i.e. when these symptoms first started coming, i.e. at school, for example, secondary school, at A-levels, around that time, because primary school, they're unable to kind of recognize what those processes are. But in secondary school, if they're able to communicate, then they're able to recognize that these are thoughts, right? And they're repetitive, obsessive. Dismiss it, come back to the present, dismiss it, come to the present, and not act upon it. Then, inshallah, that should be a way that helps them not get to the stage where it becomes overpowering, and they're unable to actually get beyond the doubt of, that cycle of going back and redoing the actions, and whether it's cleanliness, whether it's sorting, whatever the actual thing is. And that's what he mentions, and that's, I think, equivalent to, we were discussing it earlier, ACT, right?
Yeah, acceptance and commitment therapy.
Yeah.
So that's it's interesting how he mentions that years ago, way before ACT was introduced, just for the people to understand, treating OCD, you've got the CBT approaches, which consist of the behavioral approach and the cognitive approach. The behavioral approach, so generally just so that, I'll explain.
Yeah, let's go through each one.
I'll go through each one because I want to make that also the difference between ACT.
Each one, yeah.
But with the cognitive behavioral approaches, it's either the gold standard known as ERP, exposure and response prevention, exposure work or exposure therapy, which is seen to be, till this day, is kind of the recommended first to start in a kind of like a gold standard. The cognitive therapy, part of the cognitive behavioral interventions, is literally trying to challenge these thoughts. And most times in CBT, when working with thoughts, a lot of it is, as most therapists would say, is not paying attention to the thoughts. Like, don't allow, it's learning, don't entertain them. I remember I worked with someone who was pregnant and had perinatal anxiety during pregnancy, and previously she had OCD. She had CBT therapy for all that OCD, and now is starting to get mixed up with her general worries or her perinatal worries, and starting to get mixed up with the OCD. So what we learned from that is, the work that we did was, we learned from that is, put your thoughts together. When you bring your thoughts, let's first learn to distinguish between the what we call excessive worries and kind of the obsessions. Let's make that distinction. Let's learn to do that. And she could still remember the techniques that were taught from them was don't entertain them in terms of the obsessions, because our work was more on the excessive worries. So it's understanding that these things can all jumble up and they can get all piled up. But what's also important to understand here is that you're doing your level best not to entertain them. That's the CBT approach, which is kind of challenging, don't entertain them. ACT, on the other hand, acceptance and commitment therapy, is a bit different. They don't tell you to challenge or to get, to kind of we need to kind of push them aside. It's more befriending them. It's, they are there, recognizing or accepting that they are there, and making a committed action into, you're living with them, you're befriending them, whereby it's like passengers on the bus. You've got all these different obsessions. They're the passengers behind you. You're the driver, you're in the driver's seats. They don't dictate your next move. They don't dictate, even though they're once telling you to go left, right, backwards, forwards. At the end of the day, you're in control. The final say is on you. An example here, because in ACT they like to use a lot of metaphors. One is, for example, in this case, you're in a mall, you're in a cafe. There are people around you, people who are talking, engaging in conversations. You can hear, the coffee being made and all of that stuff. Or you're in a mall, you can hear so many people. You can still go on about your business even though it's quite loud. But it takes a lot of training, and that's why ACT uses a lot of mindfulness. Yeah, Sheikh, mindfulness is not a Zen, it's not about relaxation, even though part of mindfulness, there is relaxation, there is that feeling a bit meditative. But what is mindfulness? It's focusing. It really is about focusing and improving your attention. So bringing, like you mentioned, bringing your attention to the present moment, which is a skill that if we were to able to hone into, we can actually move forward. It's amazing how the Prophet ﷺ mentioned in the Hadith, for example, ihris ala ma yanfa'ak, just hasten to do the things that will benefit you. And at the end of the Hadith, wala taqul law, don't go back into what if I did this, what if I did that, what if I did. Close the door. فَإِنَّ لَوْ تُفْتَحُ عَمَلِ الشَّيْطَانِ. That low, that if, what if, the what if of the past or the if, it opens the doors to shaitan. And what does he say? استعيذ من الشيطان وينتهي. Just end it there, because you're going to open yourself into a huge door, just close the door. And continue moving on as much as you can. Subhanallah.
Yeah. Okay, let's speak about, we've spoken about the Qur'an, Hadith, we've spoken about a couple of the methods in terms of seeking refuge from shaitan. We've spoken about not acting upon it. With regards to these therapies that you've mentioned, let's break them down one by one. So what does CBT stand for? What does ACT stand for? You've mentioned, but I'd like to kind of hone in on each one specifically. define it, break it down. What is it? How does it work?
Inshallah.
How does the people benefit from it? So,
Inshallah.
the emotional response therapy, which is a part of CBT. How is that a part of CBT, for example, and stuff like that? Go ahead.
So, inshallah, cognitive therapy, which is literally changing our thoughts and behaviors so that we can change our emotions. So, our emotions are affected by our thoughts and by our behavior. What is recommended it's thought change, cognitive change or thought change, as well as behavior change. What's recommended is to start with the behavior change. Because usually what you find is that people who are experiencing, whether it's OCD or any of these problems, mental health problems, is that a lot of times it's behavior as well as thoughts. But if we start with the behavior, changing the behavior, for example, a person is experiencing depression, we get them to become more active. With worrying, we get them to learn to manage their worrying. With OCD, we get them to use something called ERP, which is an exposure type of therapy. What is exposure? It is putting yourself in the situation, but you're doing it following certain principles, around 4 principles. Number 1, it needs to be graded. It's like climbing up a ladder. It needs to be graded from the easiest or least provoking. It needs to be from the least provoking situation, going to the medium, and then going to the most. But you start from below. You're climbing up a ladder, because as you climb up a ladder, you become you start with the easiest, you become comfortable, and as you become comfortable, you become confident. So you can continue climbing up the ladder. It's like learning how to ride a bike. It needs to be prolonged. You need to prolong that situation. So you're in a situation where it's easy. You're prolonging being in that situation, sitting in that situation. You need to repeat it. Third principle is you repeat it as many times as you possibly can. And finally, number 4, you prevent. This is where the prevention comes in. You prevent yourself from engaging in the compulsive behavior. So I'm going to sit in the situation. So for example, let's take the example of salah. Salah comes in and you're wondering whether I made wudu correctly. Did I miss out? Did I wipe my socks? Or was I, or if you wiped your socks, for example, did I miss out the elbow and all of that? Or did I say Fatiha properly? So it can get you to that extent. So what's happening there is you just sit with it. And you prevent yourself from engaging in the behavior, which is repeating the salah or repeating your wudu, as an example. So if you follow that, that's why is ERP very important, exposure and response prevention, is because it will allow you to build confidence and to reduce the compulsive behaviors. If that helps, because what's happening, Sheikh, if I may, in OCD, a lot of people have a lot of shame, a lot of guilt, hence why there's a huge percentage of people who do not seek treatment because of that shame and guilt, especially when it comes to the religious side of things or issues to do with morality. I dealt with someone who had a lot of OCDs. His OCD was a lot of his obsessions were around sexual issues, and he felt very embarrassed about it, which is understandable. And from the Islamic context, a lot of it is about issues of doubting our deen, wudu, and other issues, which is very uncomfortable. But in order to build that confidence and to overcome that shame and guilt, ERP is very effective. Now, when it comes to obsessions on their own, like CBT works on the cognitive side, challenging these thoughts, or, like I said, learning to not entertain them. That's with CBT. Let's come to acceptance and commitment therapy. It's more about the goal for acceptance and commitment therapy.
Stop you a minute, just one second. So
So
the CBT, within CBT you've got, so CBT is cognitive behavioural therapy, looks at the cognitive, your mind, behaviour, your actions, and therapy around those two. And then you have exposure, response. Tell me a bit about the response, because I didn't quite pick up on the response.
It is part of CBT, it's the behavioural intervention. So the exposure is a type of treatment that is used for different anxieties. Used for panic, is used for fear and phobias, for example.
So you expose yourself to the action, you get comfortable with it.
Exactly.
And you change your response to the action.
Which is preventing you from engaging in the compulsive behavior.
And that's to prevents.
Exactly.
Right?
The idea is to reduce it. And I've got an example for you, Jazakallah khairan, for bringing that up actually, because the idea is, it's not about, and I want viewers to understand, it's when we talk about overcoming these problems, it's not about you get rid of them 100%, but it's reaching to a point where you can manage them. So for example, if a person was repeating wudu, for example, 10 plus times, but if you can get them to down from that 10 plus to 3 times, then alhamdulillah. It's not about getting it down to 0, even if it's just 3 times, but it's not going overboard. I'll give you a good example. This is not to do with salah, but this is someone I worked with back when I was in Oman. And this person, he had diabetes and hypertension. In diabetes, you have the blood checker that you have to prick yourself many times. Now, he had the obsession of, there's something wrong with me, I feel something weird. Is it my blood pressure is increasing or my blood sugar is increasing? So what he used to do is he used to prick himself with that checker, the blood sugar checker, 20 times. Very painful, very disturbing, very filled with discomfort. Using the ERP approach, exposure and response prevention, we managed to get him from 20 all the way down to 3. He's still doing it 3 times, but it's better than 20. We managed to get it down. And now he's feeling like, okay, now it's manageable. Not unmanageable or uncontrollable. It's all over the place because I'm doing it 20 times. Imagine how painful that is. But what the idea is, reduce it as much as possible. That's the idea. Because as you're reducing it, you now feel empowered and you have this sense of control. It's not over empowering me, rather I feel empowered. I feel like I can now have this sense of control.
And I think for the wudu one, and people that repeat wudu, they would have come across it, they should know anyway, that when you make wudu, so you wash, right, your face, mouth, nose, hands, arms, include the elbows, right, your feet to the ankles. And washing once is mujzi, it counts, it's valid. Second and third is recommended, it's sunnah, right? So what I mean by that is that even when you wash once, it counts, the second and third. So if you've done it 3 times, you should be completely confident and happy that you've done 3. And I only picked up on that because you mentioned the numbers just now, right? Someone doing it, repeating their wudu 3 times. But if they did it just according to sunnah every time, which most people do anyway, right? They do it 3 times for each body part anyway. You already have that reassurance that you've done it. You've washed that arm 3 times, washed your face 3 times, right? Where if you did just once, then you might think, okay, well, did the part go on there? But 3 times, then you should be confident and comfortable that it happened. Okay, so that's the CBT and ERP.
ERP now.
What's ACT or ACT, and why is it different? And in my reading, it seems to me that it's more in line with Islamic principles. I could be wrong. I'm not saying everyone's not in line, because we have that dalil, which is mas'alat al-mursala, something not mentioned, either prohibited or allowed in the Qur'an and Sunnah. Then there's a general benefit, then you allow it. If there's a harm, you don't allow it, right? So without doubt, there's a benefit in CBT, there's a benefit in ERP. ACT, what is ACT? Break it down, define it, and talk about it a little bit.
Inshallah, Jazakallah khairan. The goal and objective of ACT, acceptance and commitment therapy, is to reach to psychological flexibility. And how you do that is learning to, a lot of it, as it says, there is acceptance, accepting and adjusting to your situation, accepting thoughts. A lot of the times it's about accepting thoughts, learning to diffuse your thoughts. What they call cognitive diffusion, so kind of diffusing them in a way. And what you're doing here is you're not, again, separate to CBT, where you're challenging them, you're trying to, work around them, you're trying to put a lot, there's a lot of like challenges, kind of fighting thoughts, but here it's more like you befriend them. You are not necessarily challenging them, you're more befriending them. As an example, the metaphor of the passengers of the bus. So and there's many different metaphors that I can give, but it's passengers of the bus, for example, that metaphor where you're the driver of the bus, you've got passengers behind you. All these passengers are saying so many different things. They're annoying, they're really debilitating. Let's put them as obsessions now. For example, they're all telling you different things, but at the same time, you get to be in control because you're at the driver's seat. You don't have to follow their instructions. But you have the final say. And firstly, I think I mentioned to you that a meta-analysis and a systematic review has been published this year, obviously, where they've combined all these different studies, and they've shown that mindfulness and acceptance and commitment approaches have shown to be very significant, they will produce significant results. And what they want, it's not about replacing ERP or CBT, but they can complement one another. Actually, in another study, like I mentioned, published in 2018, they saw that by integrating randomized control trials, they found, so they looked at ERP on its own, and then ACT with ERP has still shown positive results. Actually is even said to be even highly effective if you were to integrate and combine or add them at the same time. Because with ERP, like I said, you're dealing with that, you're dealing with, working on reducing compulsions. But ACT is important. Why is ACT so important? Because here you're helping towards not only acceptance, but understanding psychological flexibility to come to that emotional mental equilibrium, whereby it deals with issues like shame, the guilt, and understanding that these thoughts don't necessarily define you as an individual. Just because you have these thoughts doesn't necessarily make it true, and it's not going to define you necessarily as an individual. Just because you have these thoughts doesn't mean that you are a bad person, you are terrible, or you are perhaps disgusting and etc. Because they might feel that way, and that's where, subhanallah, both CBT and sort of ACT really, they do in line with a lot of the Islamic principles in a way. And although, like you can see from Balkhi and others, they've already, like the Islamic principles have already shown us very similar things. But we can benefit from them both. And alhamdulillah, because like I mentioned to you earlier, nowadays a lot of studies and a lot of professionals in mental health are starting to realize that traditional CBT on its own is not necessarily enough. It needs integration and adding with other approaches.
Do you think there's a kind of a argument for that different people, different therapies work? So for example, if somebody has tried CBT, I think one of the problems we have is that most people, they won't even go to therapy because they're ashamed and they don't want to talk about it in the first place. So that's one hurdle to get over. But then when they do go to therapy, they see, okay, well, this isn't working, so why am I bothering? And they stop. Can't we just say it's a case of, okay, that hasn't worked, now try this instead, try ACT, EP, what's it called, EPR?
ERP.
ERP didn't work, okay, go and try ACT, because ACT might work for you where ERP didn't work for you. Because the thing is, one of the things I came across is that the problem, or a problem with ERP that ACT solves, is like you said, the friendly and the challenging. You're by challenging it, it's almost like you're saying, okay, it isn't logical, so don't act upon it. It doesn't make sense, right? It's not logical but the brain at that time can't necessarily think logically especially if it's what's qahri, right? If it's really bad. There's no logical thinking. The brain's not wired properly at that moment in time to think logically, which is why sometimes they go on to a third treatment, which is medication. We'll speak about that in a minute, right? So the brain can't always think logically, where ACT can maybe come in between you taking medication, because it's not saying that your mind's thinking illogically. It's actually just saying, do you know what? Oh, there's that thought again.
Exactly.
And then come back to the present and continue what you're doing,
exactly.
Right?
Yeah.
Commit to your present action that you're doing and not act upon the thought which is just surfaced.
Exactly.
So is it possible that you can say, for example, okay, for somebody that's got, OCD or, intrusive thoughts and actions, number one, there's no harm getting therapy, obviously, go get in some CBT or speak to somebody. But number two, if the first thing doesn't work, look at something else, try a different strategy, right? Is that something that
definitely
we can do as well?
I would say definitely, because it's integration is helpful, is really, really effective. And the thing is, this is why I recommend people get assessed. The assessment needs to help. When we do assessments, for example, is understanding not only what the problem is, but what's surrounding it, and understanding the other factors. For example, I did not mention this, there is, apart from like ACT or CBT, some people, they might go and have psychodynamic therapy or counseling. And the psychodynamic approach is a lot to do with, resolving past issues during childhood. So it's taking a trip to the past and try to resolve those issues. Because a lot of times, and one of the main causes, actually, one of the causes of OCD and many others, but OCD in this case, is past experiences that have led to this. And sometimes there's an issue where a person is still struggling to resolve certain past issues. So sometimes, in that being the case, maybe CBT and ACT might not be appropriate. It might be more something that's psychodynamic, or something that's more, similar to psychodynamic that relates to dealing with issues of the past if needed. But it's important for brothers, like for everybody, naturally, seek support. The support is available, there's no shame about it. But it's important that they understand what the problem might be. I think integration really helps because it can be difficult when you're being told that, it's illogical. And remember, a lot of these approaches were developed in the West.
Yep.
Because that's how it was taught. It's very, perhaps methodical. It's either black or white, it's either yes or no. The idea is
and it's devoid of religion. It's
exactly, because it's secular.
It's secular. It's devoid of that aspect of shaitan and waswas, and it's devoid of the spiritual side.
So it doesn't take into account
that there is
exactly. So it doesn't take into account there are these whispers, what they might call supernatural now, but it's like there are these whispers that shaitan comes and whispers into us, but it's understanding that these thoughts come, and subhanAllah, the Qur'an and Hadith have shown us clearly that these thoughts will come. And we're not the first, we're not the last. It's come before us and it's come after us. Allah subhanahu wa ta'ala, He says, أَحَسِبَ النَّاسِ أَن يُتْرَكُوا أَن يَقُولُوا آمَنَّا وَهُمْ لَا يُفْتَنُونَ. Do the people think that when they say that they believe they have iman, that they're not going to be tested and trialed? وَلَقَدْ فَتَنَّ الَّذِينَ مِن قَبْلِهِمْ. Those before you, you're not the first and you're not the last. Those before you have been tested and trialed. Your fathers, your forefathers, everybody's been tested and trials. فَلِيَعْلَمَنَ اللَّهُ الَّذِينَ صَدَقُوا وَلِيَعْلَمَنَ الْكَاذِبِينَ. So that Allah will know who are truthful and who are not. But those before you were tested. If the Anbiya, the prophets and the messengers were tested, then Adam alayhi salam, he fell into waswas, of shaitan. So it will come, and the Prophet ﷺ has mentioned that he will come to us and say, say X, Y, and Z. But the solution is, and it's been given, seek Allah's refuge, put an end to it, and try your best not to go further, because it's just going to open up doors.
There's another kind of discussion that's around these disorders, right, which we now call neurodivergent as opposed to neurotypical ways of thinking, is medication and the medication that's given. So how effective is it? Is it really there's a chemistry in the brain where if you take this medication it changes the chemistry so you get cured, or is it something that allows you to basically have a function while you're taking therapy to learn how to deal with the thoughts? What's your take on it?
It's highly recommended. The combination is what's always recommended, combining medication and therapy, or therapy, counseling and psychological approaches. So because what medication does, it will reduce the symptoms bi-idhnillahi ta'ala. With the therapy or the psychological treatment, it's just teaching you how to cope with it, how to deal with it, how to manage it, how to overcome it. This will not teach you how to do it, because it's basically prescribed, take this a couple of times a day, that's it, and you make your way. But here it's teaching you, a lot of it is learning how, and part of the learning here actually is, this is where it becomes adapt. You adapt as professionals, as clinicians. We learn to adapt. We understand the person, what's going on. So we use these principles and all these different techniques, but understanding the person, because it's not a one size fits all. It's not like take this pill, take that, that's it. It's, we use these treatments, these techniques and these tools, but it's understanding the person and tailor it around them as much, especially like I said, neurodivergent. So we need to tailor it around them. People coming from different cultural backgrounds, tailor it around them based on their understandings, because the one who's having, for example, if we want to talk about religious OCD, the Christian might have it differently compared to the Muslim. They might have religious OCD, for example. A person who has OCD from one particular background might have it differently from another background, because they understand it differently. And it's important to understand that medication is helpful, even though there's I remember one of the psychiatrists I worked with, he's retired now, but I remember he's told me that there's this huge debate between whether it's the medication that's causing the problem or is it the nature of the condition. He said it's still something until this very day, it's still something. We're talking about years and decades of constant debates. Is the condition itself causing a particular problem, or is the medication an add-on, or is it just worsening and exacerbating the condition? Allah knows best. Some may say it's the medication, the other argument says no, it's the condition. So
this is what I'm hopeful for, is us speaking about these topics allows viewers to go and research it and read and educate themselves more, because I find obviously in our society now, look, You got a doctor can prescribe a medication that costs, let's say it costs what, £10, £20, right, on the NHS, or £7, £9, however much the prescription is, and that's going to be for a month. Whereas the alternative, which is, let's say talking therapy, you can get access to it for 10 sessions maybe, and after that you can't get access to it, right, because it's more costly for the NHS or for the health system, the Department of Health, than it is to prescribe medicine. On top of that, whenever I say more costly, obviously you have to pay a salary, right? And that's, let's say for example, it's
more time as well.
It's more time. It's more time. So here's a medication. You take medication. It's gonna, and that's just a medication. It's on you. There's no time.
See you after a month or 3 months. Or
see you in 3 months' time, right? And that appointment with the GP was 15 minutes, right? They do 15 minutes. Now it's 10-minute appointments. They want to squeeze in as many people as possible. Not to mention that aspect of the lack of impartiality, because we speak about it's one system, so the GPs are somewhat, let's say, incentivized to give certain types of medication or to give particular branded medication, so there's that aspect as well, which obviously that's another story, corporations, all the other stuff. We'll park that for now, but just on the cheapness of it and the expense, if this treatment, which is, let's say, actual therapy, which is actually dealing with the issue, not just dealing with the symptoms for now while you address the issue, if that costs so much more money, so it only becomes available in a short burst, 10-minute sessions, talking therapy, that's the one that's free. Other than that, it's, let's say, £40, £50 an hour to have a weekly session, that's 1 hour session. People can't afford it.
True.
So they don't get access to it. So one of the ways I think is really important in the time we live in is this discussion hopefully allows people to actually, I won't say self-diagnose, but to somewhat understand what this thing is, and then do more research, especially because today we've got obviously ChatGPT. It can help in terms of giving you can put in something and say, okay, this is what I'm going through, this is what's the techniques that they would do. Do you know what I mean?
Exactly.
I think it can help a lot.
Definitely. AI has shown to be very powerful. I remember one of the first ones was called the Woebot. This was developed in Stanford. It's an app. There's now another one called Wisa, I think it's a Wisa, and then you've got these different ones where they're using AI models. They won't replace therapy, but they help reduce symptoms. I remember the Woebot mentioned that in Stanford they used the CBT model. It was an AI chatbot that was available 24/7. You can ignore it as much as you want to because it doesn't have anything else to do but to help you. That's what it's been programmed to do. But it won't replace therapy per se, but within 2 weeks, it will help you to sort of alleviate your symptoms. Not only that, but learning. That's why part of treatment is a lot of what we call psychoeducation. That in and of itself is very helpful. Learning, understanding the cycle, the vicious cycle, understanding what happens, understanding thoughts, behaviors, emotions, etc. Understanding, for example, when you're panicking, something called the flight or flight response. So understanding these things make a huge difference. But then obviously if you want to go further, that's up to you. So it's important that people do educate themselves, be mindful of over-diagnosing obviously, but at least learn a bit more about it. What resonates with you, what does resonate with you, so that you're more aware of it.
Because I mean, I think it was like a family member, relative, it was actually my mum actually, so she had talking therapy, and at the last session I wanted her to have more, so I used what you mentioned, that where you can get another 12 sessions, and the guy said basically that, look, all we'd actually really do would be go over the same symptoms. I've given her the techniques to how when this happens do this, when this happens do that, and it's up to her to actually apply them, and if she doesn't apply them and implement them, then it's not going to work. But since she's learned how to apply them, she now just has to apply them. Whereas if you've obviously got access to money, or you've got access to would you advocate for actual therapy being available on the NHS like they give medication for the same types of diagnosis?
That'll be helpful, but it's at the current status, it's going to be really difficult. I mean, that's what people would hope for, because again, it all comes back to funding, commissioning, and all of
That's
that.
right, the
I mean,
cost.
that's
It's budget.
For example, in NHS talk therapy, when it was first developed back in 2007 and 6, I mean, this went all the way to, you know, the government. They said that we need to do something about this, because what they found was the funding was only given for psychotic symptoms and conditions, for schizophrenia and things that were already hospitalized. We don't have much on the ground for anxiety and depression. We need to do something. So they agreed, okay, but it's all based on funding and commissioning. If there's no funding, then we're in problems.
I mean, I guess something's better than nothing, right?
Alhamdulillah, alhamdulillah. It's accessible nationwide. Every borough has, subhanAllah, there's not a single borough. Like, for example, let's talk about London. With all the London boroughs, there's not a single borough except there's a service. There's a talking therapy service for every single borough. And alhamdulillah, they've developed over the years.
It's got a lot better.
They're dealing with so many conditions. So for example, now you've got your core team, and now you have what we call an integrated team that deal with long-term conditions. So something I work in, for instance. So it's been developed. So there's a lot of movement, but you know, there are we've got our limitations. We have our limitations, but I do recommend to a number of, you know, to many our viewers, I do recommend seek out the support. Perhaps it might be a struggle. I understand that you might not get someone who might be Muslim, but there are more Muslims now that are applying for it. You have a lot of Muslim staff, so inshallah you're fortunate. And something, just as a side note, I hope I'm not saying this, but as a side note to people, you can actually ask for a preference. Just letting all the viewers know. So for the viewers, you actually can't ask for a preference. So people can ask for preference if they prefer to have a female therapist or a practitioner or a male or someone from this background. You can actually, as a side note, you can ask for that preference. Well, inshallah khair. Hopefully it all works out.
It's important because I think one of the things that a lot of the Islamic or Muslim psychologists now are saying is that, look, counsellors and therapists, if they're dealing with Muslims and it's the issues of religious faith, they have to understand the culture and they have to take that into account when they're doing their practice and their counselling, which is really important. Okay, just as a question, and since we're on this topic, what advice would you give someone who is struggling with OCD generally, and then secondly, religious OCD, if we're going to use that term scrupulosity or something.
Something like that. Okay. For someone who's experiencing OCD, first of all, the Hadith that reassures you that Allah subhanahu wa ta'ala tajawaz. You know, He's pardoned, forgiven, and looked over any thoughts that come to your mind, so long as you don't utter and you don't act upon them. So, and even if you did act, and just ask Allah subhanahu wa ta'ala for forgiveness, and know that Allah will overlook it. Allah knows your situation. وَخُلِقَ الْإِنسَانُ ضَعِيفًا. Allah has created us weak. Allah knows our situations, and ask Allah subhanahu wa ta'ala for help. For indeed Allah subhanahu wa ta'ala is the best of all helps. And seek help, which is a means of seeking. Part of seeking help is you know, go to the means. See your GP, see if you can get access to talking therapies. If you prefer to go private and you can afford it, by all means go for it. Seek the help, seek whatever help that you can get. Perhaps you can learn about it as well. You know, do look into research about what OCD is, what relates to you. Look for CBT guides. You might find free guides that are available. I don't know if there's one I could share. Maybe we can add it in the description. So there's a one from the NHS. They have a really nice guide that we can really benefit you for free using CBT tools. So learn about that. So seek the help that you need. I would also say to, you know, and also just generally I would say, for family members, understand that these things happen to people, and it's important that we need to really we need to take a supportive approach to this. The religious side of OCD, I would definitely say, you know, speak to experts, both religiously and psychologically. Speak to the experts, because it's important to understand. And I would also say, Sheikh, and this is something I think we all need, is knowledge, al-ilm. Because knowledge, I remember that one of our mashayikh back in Oman mentioned once that when he was going through, just before Ramadan, the etiquette of Ramadan, he talked about you know, preparing for Ramadan. There was the issue about, I remember he mentioned a short statement which was, knowledge helps deal with doubts, because knowledge gives you certainty, and certainty will overcome doubts. And when you overcome doubts, you will be able to worship Allah subhanahu wa ta'ala with ease. So knowledge is really important. We need to learn about, for example, when it comes to religious OCD, we need to learn we really need to learn the fiqh of salah, the fiqh of wudu, understand what they are so that we have more certainty of what we're doing. We ask Allah subhanahu wa ta'ala to make it easy for us.
So inshallah, I think with that we've covered in a roundabout way different aspects of OCD. Yeah, no, it's a huge topic, and I think there's so many different scenarios, different manifestations of OCD, different types. It's hard to kind of deal with all of them, and I didn't want to just focus on the religious one only, because I think it's broader than that, right? Just the fact of having to repeat your wudu, repeat your salah, that's when it becomes qahri. But generally speaking, a lot of people have intrusive thoughts, have thoughts which they might, feel uncomfortable with if they spoke about them, because, I think it's important to just realize that, it's important to get over that, accept the thought, get over the fact that, don't be afraid of it. Live according to your values, for example, not according to your fears. I think that's an important advice as well. What are our values as Muslims? Let's live by those values and not by the fears that we have from our thoughts. But also just to know that you're not alone. The person it's not something that only you have. So it's good, especially from a young age. And I think this is where the challenge comes. The challenge comes is when young people start to get that's where the anxiety and the fear comes. Why am I getting these thoughts, right? And they don't want to speak to anyone about them because they're not going to speak to their parents. They might think that they're bad. But I think that it's important to kind of know it's okay to speak to. There's talk therapies, for example. That's another question. At what age can you access it, or is it? So
when initially it was introduced, it was for adults, and in the last couple of years, just before COVID, they've introduced it for CAMs, so for children and young people. Yeah. So now you have it for all ages. Amazing. You have it for CAMs, children and adolescent mental health services, and also for adults 18 plus. So children can get access because there's a high percentage right now on the population of amount of children and adolescents and young people who are getting OCD. And not only accessing who are getting OCD, who have OCD, and if it's not dealt with during that time, it get worse later. But if it is dealt with that time, they have later on in life they can live a more fulfilling life. Yeah.
And I think it's important. I think it's really important for people to understand that it's not abnormal.
No.
You know what I mean? It's far from abnormal. That's where this classification of neurodivergent and neurotypical helps a little bit, just to highlight that you're just in that category of people, a group of people. Sure. You're not by yourself. Exactly. So there's loads of other people like you having OCD and just about managing it. And I think one of the hadiths that has really benefited me in terms of any type of tribulation that a person goes through is a hadith of the Sahabiya that complained to the Messenger of Allah about having seizures, right? And she came to him complaining, but asking him to make dua to Allah subhanahu wa ta'ala to stop her having seizures, because it affected her, right? You have a seizure, it affects you, right? And sometimes, I've seen people that have seizures. The seizure depends on how long it is, depends on how long the recovery time afterwards is, right? My sister's had seizures, and she has seizures. If the seizures, not just the fact that you can fall over and hurt yourself and other stuff, but if it's a long seizure, then it takes a day or 2 days to recover fully, right? And a student that has seizures, and sometimes afterwards he can't walk properly, he loses proper strength. So there's that recovery time. So you can see someone would want that to stop, right? They'll be making dua, giving sadaqah. So she came to the Messenger of Allah with that complaint, right? I have seizures, I want them to stop, make dua to Allah that it stops. Which is reasonable, right? So the Messenger of Allah said, look, I can make dua that your seizures stop and they stop, or you can be patient and your reward will be paradise. In other words, learning to live with it, right? This is how what Allah's given in terms of ibtila, but He's given it to you because there's a great reward for you at the end of it, paradise, right? So the hope, giving her hope, right? So who's going to say no to that?
That's true.
Right? The dunya is short, life is short, right? You're going to have ibtila anyway. So this one guarantees you paradise. Okay. So she said, I'll be patient, but, and this is the key part as well, this is why this hadith is so important for me as an anchor, one of those hadiths which are anchors. She said, but when I do have the seizure, I become exposed. My aura becomes exposed. So she has values, integrity. She has make dua to Allah that my aura doesn't become exposed when I have the seizures, right? So again, so it's now got to the stage where, okay, I'm accepting that I have this thing, but it needs to be managed in a way that doesn't cause me extra discomfort or uncomfort, right? So the Messenger of Allah made dua that when she has a seizure, her aura's not exposed, because that's obviously extra embarrassment that, how do you live with that? My aura's been exposed. Well, she has that honor, that integrity, right?
SubhanAllah.
So,
if I may add, just got me thinking about this one hadith of the Waswas. And again, the patience when you're going through a trial, إِنَّ الْعِذَمَ الْجَزَاءِ مَا عِذَمِ الْبَلَاءِ. The greater the trial, the greater the test, the greater the reward will be.
So, to me, that hadith, it signifies accepting what you have, right? That's why I prefer. If I'll be honest. Once I was doing the reading and research, and I came across ACT, I thought, this is the one. Right? Obviously, you work in the field, and you said the gold standard is the CBT, which I know is as the overarching.
The mainstream at the moment.
The mainstream is CBT, right, at the moment. We've got to talk about medication, actually, the pills. You spoke about it briefly, but you mentioned something before. I'm going to come to that right after this. This hadith, it shows me, accepting it, but moving forward and how you move forward, right? And coming back to it's not necessarily OCD, it's actually a physical condition as opposed to a mental one, right? In this case of the seizures. But it's just a case of accepting this is me, this is how I am, and not letting it have a negative impact on your living, your daily, i.e. you're going to still live. You mentioned a treatment which is the last kind of treatment that they offer, which is, it sounds a bit drastic. There used to be an older one which was like someone putting electricity in you or something.
Yeah, right? so the one I was referring to is TMS, which is transcranial magnetic stimulation. It's like this magnetic machine that places all above your head, and it's used for severe clinical depression, anxiety, many other problems, OCD as well. And previously they had something called ECT, which stands for I usually get it wrong sometimes, electroconvulsive therapy. Two kind of like electric rods placed on the head, and it's not a Frankenstein type of thing, but it's literally
sounds like it.
It sounds like it, but it's literally the idea is that the electricity, it's kind of like, it's used, the electric currents, they pass through the brain, and it's meant to kind of like, it kind of does cause a brief sort of seizure, but it's like, it is meant to provide quick improvements. But this has been done many years ago, was developed many years ago. Usually psychiatrists do this, but it's the last option. Always kept as the last option.
It sounds like jump starting a car when the battery's dead. It's like car's not starting.
That's it. Last option. You can't change it. But the idea is that transcranial has been shown to be transcranial magnetic stimulation has been shown to be proven to be very effective. But it's always kept as the last option. Hence why you don't find a lot of them around. They're like very few, very minimal are around. Yeah. But the idea is that this is when whenever you've tried everything, you've tried medication, you've tried psychological treatment, and you're not seeing a lot of results. Yeah. So this is sort of the last treatment option, and obviously that really depends. This is something that psychiatrists among themselves or doctors among themselves need to discuss. Shall we consider this or not? So this is not something they would recommend at the start.
That's right, yeah. And again, it's only for those that can't live with their condition at all. It's the qahri one, it's an overpowering, overwhelming.
Depending on the severity.
Like how it's got really severe basically in that case. Okay, alhamdulillah, I think we've discussed a lot. We've looked at the mind, we've looked at the body, we've looked at obviously the religious aspects, the soul aspects of it as well, to do with OCD, inshallah. And hopefully there's been some benefit for the audience and for the viewer, inshallah. And that brings us to the end. I guess this session, what we're going to be speaking about next?
I think we said we're going to look around, since you mentioned medication, and then looking at sort of, that and lifestyle changes and behavior changes, how can we make other changes, and why lifestyle, for example, is becoming the new approach. It's what a lot of doctors are trying to emphasize, and how can we work towards that? Okay. And bringing the Islamic sort of theme to it as well. What does Islamic psychology say around lifestyle changes and behavior changes? Yeah.
Amazing. Jazakallah khairan. Until next time. Assalamu alaikum.